Greetings. Have you ever heard of a medical emergency that starts with a sudden, thunderous headaches, then steals your vision, your consciousness, and even your hormones? This is pituitary apoplexy, a rare but life-threatening condition that strikes the pituitary gland, the tiny master controller of your body's hormones, tucked at the base of the brain. Pituitary apoplexy happens when there's sudden bleeding or lack of blood flow, a hemorrhage or infarction into the pituitary gland. Most of the time, this storm brews within a pituitary adenoma, a benign tumor that has been silently growing undetected for years. When that tumor bleeds or swells rapidly, it pushes on nearby structures like the optic chiasm and even the brain itself. The result is a medical emergency. The classic symptoms strike like lightning: a sudden severe headache, often retroorbital, meaning behind the eyes, then visual disturbances from blurry vision to a full bitemporal hemianopsia or double vision due to a cranial nerve palsy, nausea and vomiting, altered mental status or sudden collapse, and crucially, acute adrenal insufficiency, which can be fatal if not recognized. This is why pituitary apoplexy must be in the differential diagnosis of any patient with a sudden headache and visual changes. What causes it? It may occur spontaneously, but several triggers have been identified, which are use of blood thinners or anticoagulants, major surgery or trauma, dynamic endocrine testing, pregnancy, dopamine agonists used in prolactinoma management. Often though, there is no clear warning. How do we diagnose it? Time is crucial and imaging is key. An MRI is the gold standard. It shows a cellular mass with signs of hemorrhage or infarction. A CT scan can be faster in emergencies and may reveal a hyperdense lesion, but it is less sensitive. And don't forget labs. Cortisol, TSH, prolactin, and electrolytes help assess the presence or absence of a hormonal crisis. How do we manage it? First things first, we have to stabilize the patient. Then we start high-dose intravenous hydrocortisone even before lab confirmation to prevent an adrenal crisis. Then we manage fluids, electrolytes, and blood glucose. If there is visual loss or decreased level of consciousness, an urgent neurosurgical decompression, often via transsphenoidal approach, is needed. For stable patients with mild symptoms, conservative management with close monitoring is safe. Now, recovery depends on how early the treatment starts, but up to 80% of patients will develop long-term pituitary or hormonal deficiencies. This means that many may need lifelong hormonal replacement, like cortisol or thyroid hormone or sex steroids. Regular follow-up by an endocrinologist and repeat MRIs are essential. But remember, pituitary apoplexy is rare, but when it strikes, fast recognition can save sight, life, and long-term health. So next time you see a patient with sudden severe headache and visual changes, think beyond the obvious. Think about the pituitary, think about apoplexy, and think fast. Thank you for listening and have a blessed day.